Assalamualaikum and good day to everyone. First of all, I would like to thank the organizing committee for giving me this opportunity to speak in this prestigious conference. The topic that was given to me is damage control resuscitation. So for the next 15 minutes or so, I will try to explain to you the concept of damage control resuscitation and hope you can benefit from it and bring back some of the points to be practiced at your place. I'll start with some introduction to damage control resuscitation. Damage control is originally a Navy term, which is defined as the capacity of a ship to absorb damage and maintain mission integrity. The adaptation of the term damage control to the field of traumatology was first described by Schwab and also Rotondo when they published a paper entitled Damage Control, an Approach for Improved Survival in Exsanguinating Penetrating Abdominal Injury in year 1993. DCR is a strategic approach to the trauma patient who presents in severe hemorrhagic shock. It consists of four main components. The first component is permissive hypotension, whereby hypotension is temporarily allowed to prioritize coagulation over perfusion until hemostasis is achieved. The second component is hemostatic resuscitation, characterized by early blood product administration and also hemostatic adjunct. The third component is prevention of acidosis, hypothermia, and hypocalcemia. And last but not least is early hemorrhage control, which is achieved through damage control surgery. The principle of DCR is to restore hemostasis and mitigate the development of tissue hypoxia, oxygen debt, and coagulopathy. DCR is a structured intervention that begins immediately after initial assessment in the pre-hospital environment itself, and it progresses through ED and then to OT or IR suite, followed by ICU and finally definitive care. Bear in mind that surgery does not follow resuscitation. It is actually a part of resuscitation, and DCS is a component of DCR. Now we'll go to the first component of DCR, which is permissive hypotension. Permissive hypotension is done to prioritize coagulation over perfusion in a severely bleeding patient. During this phase, fluid administration is restricted and hypotension is temporarily allowed until hemostasis is achieved. If the blood pressure is pushed up too high, this will increase the intravascular hydrostatic pressure and will disrupt whatever clot that has been formed and cause more bleeding. The European Guideline on Management of Major Bleeding and Coagulopathy recommends permissive hypotension with a target systolic blood pressure of 80 to 90 or a MAP of 50 to 60 until major bleeding has been stopped in the initial phase following trauma in patients without brain and spinal cord injury. During this phase, try to avoid or minimize crystalloid infusion because crystalloid infusion will lead to multiple complications such as dilutional coagulopathy, metabolic acidosis, hypothermia, and later on it is highly associated with multi-organ dysfunction. This diagram shows the adverse effect of aggressive volume resuscitation to normalize the BP in a bleeding trauma patient. It can lead to multiple complications such as dilutional coagulopathy. It can worsen the bleeding by disrupting the formed clot. It is found to prolong ICU stay. It can lead to ARDS, abdominal compartment syndrome, SIRS, and also multi-organ dysfunction. Okay, now we move on to the second component of DCR, which is known as hemostatic resuscitation. Hemostatic resuscitation is a key component of DCR. It involves early use of blood products such as whole blood or blood components and adjunct therapy to manage coagulopathy and attain early hemostasis. Ideally, any lost blood volume must always be replaced with blood. Replacing it with any alternative fluids such as crystalloid would only compensate for the loss of volume, but it would never replace its integral function. Moreover, overzealous resuscitation with non-blood products will lead to aggravated hemodilution, acidosis, and worsen the existing coagulopathy. Coagulopathy was historically viewed as a byproduct of resuscitation, hemodilution, and hypothermia. However, this theory has been proven to be incorrect. The process or the occurrence of coagulopathy following severe trauma is more complex than that. Acute traumatic coagulopathy, which is a form of endogenous coagulopathy, is found to occur prior to significant dilution within half an hour from the injury. It affects about a quarter of patients with severe trauma who are in shock, and it is found to be associated with higher mortality. This diagram shows how acute traumatic coagulopathy takes place through the activation of protein C pathway. This was described by Professor Karim Rohi in his paper which was published in year 2007. Following severe injury and shock, thrombomodulin will be released from the endothelial wall. Thrombomodulin will bind to thrombin and form thrombin-thrombomodulin complex. This will indirectly reduce the availability of thrombin and reduce the formation of fibrin through cleavage of fibrinogen. Other than that, this thrombin-thrombomodulin complex will activate protein C to activated protein C. Activated protein C will further inhibit factor 5 and 7, causing reduction in thrombin formation. Other than that, activated protein C also inhibits PI1, leading to excessive availability of plasmin, which will lead to breakdown of fibrin to fibrin degradation product. This is known as hyperfibrinolysis, which plays an important or key role in the formation of acute traumatic coagulopathy following severe trauma. This diagram is showing you how a trauma-induced coagulopathy happens. It is a sum of multiple factors, such as the pre-existing condition, acute traumatic coagulopathy itself, resuscitation-induced coagulopathy, which is caused by us, the healthcare personnel, and trauma-associated factors. Following severe trauma, there will be tissue damage and hemorrhage, leading to shock and hypoperfusion. This will initiate a series of reactions systematically, namely inflammation, platelet activation and dysfunction, reduced clotting factor activity, sympathoadrenal activation, endothelial glycocalyx shedding, endogenous heparinization, and hyperfibrinolysis. All these are known as acute traumatic coagulopathy. On top of that, we, the resuscitationists or the healthcare personnel, tend to induce or introduce resuscitation-induced coagulopathy due to excessive fluid administration or imbalanced administration of blood products. It will also lead to hypothermia and acidosis. Besides that, following trauma and bleeding, there will be coagulation factor loss and also coagulation factor consumption due to repeated clot formation and breakdown. All this will lead to formation of weak clot or failure to form clot at all. Now let's talk about transfusion strategy in a bleeding hemorrhagic shock patient. During the initial phase, a fixed ratio transfusion or empirical transfusion should be administered in a 1-to-1 ratio. This will usually take place between the arrival of the patient until the lab coagulation parameters or the viscoelastic hemostatic assay results are ready. Once you have those results ready, this empirical or fixed ratio transfusion can be changed into a more precise goal-directed transfusion by using those parameters as a guide. By doing this, we can provide a more accurate or precise treatment, can save blood products, and might also improve survival of the patient. Fixed ratio transfusion is also known as balanced transfusion. It aims to approximate the delivery of blood components in a 1-to-1 ratio of plasma, platelet, and also RBC. It is usually activated through a protocol known as massive transfusion protocol. It is used in critically bleeding patients anticipated to require massive amount of transfusion. How they get activated? Usually it is activated by using or utilizing validated scoring system such as the ABC score or TASH score, and occasionally clinician uses their clinical judgment when they observe rapid bleeding rate to activate this protocol. One of the important study that emphasizes or shows the benefit of 1:1:1 ratio transfusion is proper trial. They compared 1:1:1 and 1:1:2 and found out that more patients in 1:1:1 group achieve hemostasis and fewer experience death due to exsanguination by 24 hours, thus favoring the use of high ratio transfusion or the 1:1:1 group. In my previous slides, I've mentioned that after the initial empirical or fixed ratio transfusion, can shift your transfusion strategy to a more precise goal-directed transfusion. So how to do this? There are two ways of doing this. You can either use viscoelastic hemostatic assays such as TAG and ROTEM if it's available at your center, or if you don't have it, you can always use your conventional coagulation test such as the PT-INR, fibrinogen, and also your full blood count, whereby you can look at the hemoglobin and also platelet level. Viscoelastic hemostatic assay has significant advantage in comparison with conventional coagulation tests such as PT-INR. How it functions is whole blood will be placed into an oscillating cup and a pin will rotate within it. As the clots start to form, there will be impedance within the cup. This impedance will be translated into tracing, which look like this. Viscoelastic hemostatic assay shows global hemostasis, in which it reflects thrombin generation, platelet activity, and fibrinogen cross-linking, providing a measurement of the rate of clot formation, maximum clot strength, and also subsequent clot dissolution. It demonstrates the interaction of platelet with coagulation cascade. In comparison, PT-INR only measures the plasma-dependent enzymatic component of the clotting. It is performed on a platelet-poor plasma, and it is only sensitive to the earliest initiation of clot formation, and it do not incorporate platelet function. Furthermore, the first viscoelastic hemostatic assay will be ready within 10 to 15 minutes in comparison with PT-INR, which you can only get the result after about 45 minutes to 1 hour. This is an example of TEG tracing. Believe me, it's not as complicated as it looks like to interpret it. Usually, there will be a table or an algorithm for you to decide what type of blood component of blood product that the patient requires. For example, if you look at the table here, we take maximum amplitude as an example. Maximum amplitude on the tracing is here. It indicates platelet function. If the maximum amplitude value in the table is lower than the normal value, means that patient requires platelet transfusion. Same goes with the others. For example, R time. If the R time is prolonged, there is problem with the coagulation factors and the patient will require plasma transfusion. If you are using conventional coagulation test to go direct the transfusion, the following are the values that you should aim for. For the HB, it should be aimed to be kept between 70 to 90. If anything less than that, packed cell transfusion is required. For platelet, it should be kept more than 100. If it's less than 100, patient will require platelet transfusion. If the PT-INR is more than 1.2 times normal, patient will require plasma transfusion. And last but not least, plasma fibrinogen level should be kept above 2. Anything less than 2 will require cryoprecipitate or fibrinogen concentrate transfusion. There were two randomized control trials that were done to compare the difference between VHA-guided MTP and CCT-guided MTP. The first trial was done in the US involving more than 100 patients, and it showed improved survival in the VHA-guided MTP group. And it also showed that the VHA-guided MTP group utilizes less plasma and platelet transfusion during the early phase of resuscitation. However, a larger scale RCT, which was done in the UK, known as iTactic, which also compared the same thing, VHA-guided MTP and also CCT-guided MTP. Surprisingly, it did not show any difference in overall outcome between the two groups. Apart from blood component, do not forget hemostatic adjunct therapy, which is tranexamic acid. CRASH-2 trial has shown that tranexamic acid improves survival in bleeding trauma patients. Therefore, it is recommended to be administered to those trauma patients who is bleeding or at risk of significant hemorrhage as soon as possible within 3 hours from the point of injury. It should be administered in the form of 1 gram over 10 minutes followed by 1 gram infusion over 8 hours. So what does it do? It binds to the plasminogen and prevents conversion of plasminogen to plasmin. Therefore, it stops the breakdown of fibrin to fibrin degradation product. As I mentioned earlier, one of the main pathology that happens during acute traumatic coagulopathy is hyperfibrinolysis. Thus, tranexamic acid plays an important role in mitigating this process. It is recommended that tranexamic acid should be administered as soon as possible, ideally in the pre-hospital setting. It is found that as the time lapses, the efficacy of tranexamic acid falls, and if it is administered after 3 hours from the point of injury, instead of bringing benefit, it causes harm. In Malaysia, now we encourage our paramedic to give tranexamic acid in the ambulance or in the pre-hospital setting even before they arrive at the hospital. This is just to show you the criteria that we use to decide when should a paramedic administer tranexamic acid in the pre-hospital setting. Another hemostatic adjunct that you might want to consider is prothrombin complex concentrate. However, evidence for usage of PCC in a bleeding trauma patient is not so strong. Small studies showed promising results with multiple added benefits such as reduced incidence of sepsis, TRALI and MODS, reduced number of ventilator-dependent days, reduction in the transfusion of RBC and platelets, also reduction in the requirement of volume. This diagram summarizes the process of hemostatic resuscitation. Always monitor your temperature and electrolytes as well as pH and lactate level. Keep them within the normal range. Do not forget your antifibrinolytics, which is your tranexamic acid. Start your transfusion therapy with the fixed ratio transfusion of 1:1:1 ratio, and once you get your coagulation parameters back, shift to a goal-directed transfusion. Bear in mind that this process of permissive hypotension and hemostatic resuscitation should not go beyond 60 to 90 minutes. You should aim for early hemostasis or early hemorrhage control. As you prolong this process, it will lead to multiple other complications such as MODS later on and increase the mortality and morbidity. The third component of DCR is prevention of acidosis, hypothermia, and hypocalcemia. In a bleeding trauma patient, hypothermia should be avoided at all costs. This is because hypothermia can lead to altered platelet function, it can impair coagulation factor function, it can worsen fibrinolysis, and when the temperature drops below 35 degrees Celsius, it is associated with acidosis, hypotension, and can cause dysrhythmias. These are some of the ways to prevent hypothermia. Always remove the wet clothing early. Cover the patient as soon as possible. When you administer fluid or blood products, always make sure it is warm before administered. Put the patient on heated blanket using warming device. Raise the ambient temperature if that's possible. and push the patient for rapid surgical care as soon as possible. Metabolic acidosis should be avoided as well. This is because it will reduce thrombin production, reduce fibrinogen concentration, reduce platelet function, worsening coagulopathy, and it will also impair the myocardial function. Metabolic acidosis resulting from hemorrhagic shock is a consequence of tissue hypoperfusion, which leads to lactic acid production. In order to reverse this, we must try to restore end organ perfusion as soon as possible by blood component resuscitation, vasopressor support, and early hemorrhage control. Another important component that should not be forgotten is to maintain the ionized calcium level above 1. This is especially important in those bleeding patients who receive large amount of blood product transfusion. Blood product contains citrate, which will chelate calcium, causing the ionized calcium level to drop significantly. Calcium has important roles in our body. To name few, it plays important role in coagulation function, in myocardial contractility, in vascular tone, and also thermoregulation. Thus, it is important to maintain the calcium level within the normal range. This can be done by administering calcium gluconate or calcium chloride. It is recommended to give calcium after the first 2 units of citrated blood products. Subsequently, can monitor the ionized calcium level by using your venous or arterial blood gas as a guide. The last component of damage control resuscitation is damage control surgery. Damage control surgery is an abbreviated surgery which was found to improve survival in those patients who are approaching physiologic exhaustion. It consists of 3 steps. The first step is short or abbreviated surgery to control the hemorrhage and contamination, followed by resuscitation in ICU, and later on a planned reoperation with definitive surgery once their physiological parameters has normalized. However, not all patients with initial physiological deficit requires DCS. With rapid arrest of hemorrhage as well as ongoing resuscitation, some patients will show dramatic improvement in all parameters on repeated intraoperative blood gases and might be a suitable candidate for definitive surgery on the first setting itself. Now we have come to the end of my presentation. In summary, DCR is an important concept that should be applied on bleeding trauma patients in hemorrhagic shock. During DCR, prioritize coagulation over perfusion until hemostasis is achieved through permissive hypotension and hemostatic resuscitation. Hypothermia, acidosis, coagulopathy, and hypocalcemia, which is also known as lethal diamond of trauma, should be prevented at all costs. Push for damage control surgery or early hemorrhage control as soon as possible in order to improve the rate of survival and reduce morbidity. With that, I end my presentation. I really hope you enjoyed, benefited, and learned something from my presentation today. Thank you very much and take care.